All right. This is a special day. This is the annual Zimmerman Symposium. Sharon reminds me it's the 25th year that we're having the Zimmerman Symposium, so I thought it'd be worthwhile to recall who Bernard Zimmerman is. I know that people of a certain age bracket, which includes mine, unfortunately I wasn't here, remember Dr. Zimmerman with great fondness, but some of us of more recent vintage may not know who Dr. Zimmerman was. Born in St. Paul, he was the son of a surgeon, went to Harvard College, Harvard Medical School, and did his residency under the legendary Owen Wagenstein at the University of Minnesota. He was gifted as a researcher. At age 25, he described a technique for prolonged catheterization for intravenous infusion. Can you imagine that at age 25? Single-authored paper in Science. And those of you who know the literature know that that's a singular accomplishment. Academic surgery was in his blood. He was in the University of Minnesota as a junior and associate professor. He studied all sorts of metabolic and endocrine derangements that are associated with injury and surgery, and also branched out into various clinical areas as well, such as iatrogenic bile duct injuries. He was famous at West Virginia University as being one of the wave from Minnesota, the people from Minnesota who populated the academic clinical departments at the conversion of the 2-year to 4-year medical school. And he continued an active laboratory investigation. He has 101 publications, nice round number, in his CV, and 45 of them dated from his time in West Virginia. Some sampling of the very wide-ranging and prolific interests that he had. Nutrition and body fluids, shock and burns at SGNO. That's the predecessor, by the way, to Journal of the American College of Surgeons. Early mechanisms of hemostasis after hemorrhage, and a book about the postoperative management of fluid volumes and electrolytes. That, in terms of surgical endocrinology that surround injury and trauma, was the field for which he was known. He was an innovator. He was on the founding editorial board for the Journal of Surgical Research, and he was a founding member of one of our main bodies for surgical professional organizations, the Society for the Surgery of the Alimentary Tract. He was president of the Halsted Society. So he was prominent. He had a tragically short life, and he was missed. Avocations: fly fishing, hunting, hiking. He bred Angus cattle, of all things. He was a country farmer who loved to visit his neighbors on horseback. And his wife, Elizabeth, who is still very mentally active, and sons Bernard III and Andrew, gave us a lot of the biographical information that we have today. Those of you who are familiar with the surgical suites knows that there are a number of Bernard Zimmerman's portraits in the department. The left is the one that hangs in the conference room of Dr. Zimmerman, who he was close to the end of his career and end of his life. This is the one that you're familiar with in the conference room. The one on the right, though, is in the hallway between the main administrative suite and the suite of offices on the 7th floor. That's his father. That's Harry Bernard Zimmerman. And he has an interesting life as well. He was a lifelong resident of St. Paul. He was a general surgeon. He had an academic life as well, so that explains in part some of the legacy that his son enjoyed. He was president of the Western Surgical Association, and he was an early believer in certification surgery. And if you take a close look at this, you see it's a board certification of the same kind of pattern that most of us have hanging on our walls. But if you take a look, it is the member of the founders group right in the middle. He was a founding group that had the original certification by the American Board of Surgery. And you see some of the signatures, and the one on the left is Evarts Graham, someone who everyone knows is the legendary professor and chair of the Department of Surgery at the Washington University School of Medicine in St. Louis, and Alan O. Whipple of the Whipple procedure fame, who was the chair of the Department of Surgery at Columbia Physicians and Surgeons. And if you take a real close look at the very bottom, you see that he has certificate number 29. So this is part of the legacy that we enjoy. It comes from a time when you really didn't need to have board certification to practice surgery and have a successful surgical practice, because at the time that Harry Zimmerman, the father, got this, he was quite successful in St. Louis, and he didn't need to have this, but he felt it was important, obviously, because he got in. And the other thing was that there was a time when you didn't even have to have surgical training to be a surgeon. And so he got top-notch surgical training, he got top-notch certification, and this is the kind of legacy that we in West Virginia enjoy today. What's more, though, is something else that he has, and that's this article about more human attitudes in surgical practice. This is by the father, Harry B. Zimmerman Sr., and this is something that he wrote on the humanism very early on. They didn't quite call it humanism. If you take a close read at it, you recognize that that's an archaic kind of, some of the things is dated, but the spirit is there, and I think the spirit lives on in his son and what the son brought to the Department of Surgery at West Virginia University. It's part of that legacy that we enjoy today. So it's important that we have both portraits up in our surgical suite. This is important because you remember how old Dr. Zimmerman looked in the portrait that he has in the surgical conference room, but this is what most people who work with him actually remember, and this was pointed out to me by Sharon Bartholomew. And so it's important that we recognize him, that this is the signal event of our academic year at the West Virginia University Department of Surgery. And to commemorate that, we have an updated portrait. His likeness will be hanging outside the department suites, and I'm asking the guys who really knew Dr. Zimmerman back in his prime, Gus and Rick Vaughn, to come up and do the unveiling. Will you come up? Thank you very much. In case you didn't hear what Gus said, he says, I bet BZ would be happy. And BZ, meaning Bernard Zimmerman, is his kids and his wife send their regrets, although they intended to come. It's quite some distance, and they're definitely here in spirit. So one of the exciting things about having this event is to have great speakers. We in the department want to have the old war horses, and that's why we had David Feliciano and John Hanks speak, but also we want to have the people who are going to be leading the field in years to come. And Amy Halverson, this year's Zimmerman lecturer, is no exception to that. She's a great example of the future of surgery, and also its present. I was impressed because I saw a couple of her articles in the Bulletin of the American College of Surgeons about quality in the operating room, and I thought this was right on, and I was very impressed that this young woman, nowadays everyone's younger than me, so I can call her a young woman, I guess, was leading a quality and safety effort at one of the big and noted operating rooms and operating suites in Chicago. That's Northwestern, where she is currently working. And I was even more impressed that she is also a recognized leader in the nascent field of rural surgery, which she'll be talking about tomorrow. But we'll take advantage of both of her expertises because we can certainly benefit. She's a specialist in colorectal surgery. She's part of the division of gastrointestinal oncologic surgery at the Feinberg School of Medicine, Northwestern University. She graduated from University of Utah, where she majored in philosophy and medical ethics. And because of that, I'm sure, she took a medical degree also from the College of Physicians and Surgeons in Columbia, did her general surgery training at George Washington University, where she was one of the residents with Charlie Rosen, our own Charlie Rosen from the Department of Neurosurgery. And they were reminiscing just before this meeting. She has a number of clinical interests that involve colon, rectal, and anal cancers. I've heard her speak on all those. She's an expert, but what we're particularly excited about is having her be our Bernard Zimmerman lecturer this year. She'll be speaking to us today on communication, culture, and quality in the operating room. Please join me in welcoming Amy Halverson. Thank you very much.
I'm really humbled and delighted to be here today. People thought, oh, I bet she's never been to West Virginia before. No, when I did my residency at George Washington, I would often visit some friends in Clarksburg. So I would just drive by Morgantown, and I couldn't remember the name. I was like, where's that place I used to go? I was driving here today, and I said, it's a town with a lot of funeral homes. And the person driving me from the airport lives in Clarksburg, so he said, oh yeah, that's where I live. So, today I'm not talking, let me turn this microphone on. I'm not talking about some basic science lecture. Today I want to talk to you about leadership and followership. And my goals for you is that when you leave here today, you're going to walk away with at least one communication skill. And you are going to be a better leader. Whether you're the chairman of the Department of Neurosurgery, or you're a resident just starting out, or you've been in practice here only 6 months, I'm hoping that you'll walk away from this lecture with something that's going to make you a better individual, a better colleague at work, and maybe a better person at home too. You probably think you're a good communicator. We all think we're pretty good at communication, and when this idea of improving communication in the operating room came out, this is one of the earlier studies, and they asked the individuals in the operating room, how good is your communication? They asked the surgeons, they asked the nurses, they asked the anesthesiologist. And the percentages are the percentages of individuals that rate the quality of communication and collaboration as high and very high. And if you look over here, the surgeons, 87% said that there was high or very high quality of communication. But if you look at the reciprocal, and you ask the nurses, how well is that communication with the attending surgeons? Not so good. And you can see there's also a discrepancy with the anesthesiologists, not so much. So one of the things we learned from this study is that communication is in the eye of the beholder. One of the main goals for communication is to create a shared mental model. A mental model is a picture that we have in our mind, and a shared mental model is when all members of the team have that same image, that same understanding. Woodstock. Think about, what does that mean to you? How many people were thinking of a rock concert? Is there anybody in here that thought of this? Oh, I see one hand up there about a little yellow bird. So having a shared mental model is one of the most important things that we can do in terms of teamwork and in creating an understanding. When you don't have a shared mental model, it can be a source of conflict. And this is an example of something that can happen when you don't have a shared mental model. Every day wanting to do a good job. Everyone generally tries hard, but we need to have this shared mental model, and that helps us make decisions. It helps everyone to know that we're on the same page, and we can identify when something is out of place. Take, for example, in the operating room. If everyone in the operation is sort of expecting maybe minimal blood loss, maybe a couple hundred cc's, and then the anesthesiologist looks over and sees that there's a liter of blood in the suction container, then they know that something's amiss. However, if you go look at some other surgeries, like a C-section, 500, 1,000 units of blood, or 1,000 cc's of blood loss is not so unusual. I had my first son with a C-section, and when I heard that I lost a liter of blood, I was like, oh man, I must have bled so much. And then I found out that that was actually par for the course. But I'll tell you, when you're a patient and you hear suction, 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 is this patient cross-matched? I was the only one in the room that knew I was cross-matched because there was a change of shift. And I only mention that because that was an example of the team not being clear on what was going on. I had just started doing this team training, which I'll talk about in a minute, at Northwestern. And we had instituted this idea of a checklist and doing a briefing. And as I rolled into the operating room, I'm lying on the stretcher. And I'm like, do you think I should tell people that they should do a briefing? Should I make them run through the checklist? I didn't say anything, and they didn't. But when we create a shared mental model, we have to be able to recognize what assumptions we're making. And then we need to be able to question those assumptions. And who here are residents? Do we have some residents up here? Okay. So this is going to be, I hope, a very useful technique for you. What do you say when you want to question a plan to someone that's more superior to you? Let's say a senior resident or one of the attendings asks you to do something and it just doesn't make sense to you. How can you question them in a very polite, respectful way? I think there's two words that we can use. I want to question, I want to clarify, and I want to confirm. Nobody's going to feel insulted. It's like, do you really want to give that patient 80 milligrams of potassium? Are you sure about that? I just want to clarify. And if they say yes, I want to confirm. And so that's a very respectful way that you can question what, when something doesn't make sense to you. Let's talk a little bit about what are some of the communication barriers. Hierarchy. Now, I think Dr. Nakayama is wonderful, and I imagine that he has gone a long way to setting the tone and the culture of a department that is not strongly hierarchical. And I don't know about how the department was before he took over, but he seems like such a warm, approachable man that, to me, he's like the poster child of a great leader who leads by being supportive and by being a great example, but not by being a strong, authoritative, demanding leader. And I think he's really how we envision the ideal leader should be. How about lack of awareness? We've got external distractions. We've got internal distractions. I'm told that at 80% of the time, we're either thinking about food or sex. And so a lot of people have these internal distractions. And I know, people had some appetizers, but we're going to dinner later, and so don't worry, I'm not going to go over. But sometimes we're just not paying attention. How about the environment? Does anybody here listen to loud music in the operating room? I'm not very popular in Chicago because I like to listen to country music, and I like old country music. I like Randy Travis, but one of the vascular surgeons likes to listen to that loud house music, and I think if I can feel the bass beating, that doesn't work for me, and to me that's a distraction. How about production pressure? We're all rushing to get things done. We've got a lot of things on our plate. And how about culture? And I don't know in this town how many different cultures there are, but I think even if we're not from countries from different cultures from different countries, certainly there's different cultures even from different regions around the United States, and different people and how sort of their families and how they were brought up. Some people are more extroverts, some people are more introverts, and the interpretation of what's polite is different. So this is a recent event, the tragedy with the ferry in Korea. And what barriers were there to communication in this situation? I like to read the New York Times. When I went to medical school, I got hooked on the New York Times, and I still read the New York Times. And what's interesting to me now is they have the article, but then they have lots of commentary. Everybody gets to write their opinion, and there's a lot of back and forth about the role that the culture played in this accident. Some people are saying that the Korean culture has a very strong hierarchy. And one of the crew members was quoted as saying, well, we don't do anything without an order from the captain. At the same time, there's on this discussion board for the New York Times, people are saying, listen, you can't blame it on the Korean culture. And in the past, when they looked at aviation accidents, and there was some sentinel accidents with Korean Airlines, and they've done a lot in the airline industry to try and take away this hierarchy. And actually, the Korean Airlines is one of the safest airlines in the world now. But when you look at the transcript of the communication between one of the crew members and the Coast Guard, it's very interesting to see that there was a little bit of a lack of a shared mental model. The crew member was asking the question, if I evacuate these children, are you going to be here to pick them up? And I think he was trying to find the right timing to get them off the boat into the water, but he was concerned about how they would do if they were in the water for a prolonged period of time. And there was never a yes or no answer from the Coast Guard people. They said, we're on our way. And so when you look at that, you can see there was a questioning and there was an answer, but they weren't coming together on a same understanding. They weren't creating a shared mental model of how far away are the rescuers and how soon will they be there to pick up these children. And so it's a terrible situation, but I think certainly there was some hierarchy that played a role in this. There was some communication breakdown, and certainly as the passengers sat and were waiting for orders, they were told not to move. And some of them, even their parents, are on their cell phone. You need to get off that boat. You need to do something. But at that point, the passengers weren't quite sure what to do, or by the time they realized they need to get out, it was too late and they couldn't move. So today I'm going to talk about 3 tools in the communication toolbox. One is a read back or a cross check. We'll talk about a check back. And then we'll talk about the role that a checklist plays in helping to create a shared mental model in the operating room. So I'm going to show a short video. A read back is when you read back verbatim an order or a request that someone has given you. And you read that back to them so that both of you have a clear mental model and a clear understanding. When we did this team training program at Northwestern, we introduced these clinical scenarios that were real events that occurred at our hospital. And while I was telling this story, the chairman of neurosurgery at the time was in my class, and these are classes of about 30 people. And he came in with a stack of mail about yay high. And he was the whole time opening his letters and reading his mail and looking through journal articles while I was talking. So I told this story of the neurosurgeon that was doing a case, and he was doing carotid artery, and he was working with a new CRNA that hadn't worked with him before. And as he was doing the repair, he wanted the patient to have the heparin reversed as soon as he took the clamp off. And when he wanted her to get the protamine ready so that when he asked for it, it would be ready to give right now. And so when he got to the point where he said, okay, give the protamine, the CRNA was like, I gave it 10 minutes ago. And as it turned out, this patient was a physician, and the patient ended up getting a clot Well, this neurosurgeon wasn't paying attention. And I went to talk to him a few weeks later in his office, and he was saying, you know, I really am starting to understand some of what you're talking about of this checklist and teamwork. Let me tell you a story. Well, I didn't realize, but he told me that story because that had been his patient. And he didn't even recognize that I was telling the story because he hadn't been paying attention. But I think it's important to do this read back verbatim. And a part of it is cultural. If you do it when people aren't expecting it, they might think that's a little weird. Why are you repeating everything I say? But here's an example of a read back.
An angel. Little girl?
Yes, sir.
I want you to do something very important, all right?
Okay.
I want you to run. I want you to call ER, North Bank General Hospital, 932-1000. Tell them to set up OR6 immediately and contact anesthesiologist Isadora Turek, 472-2112, beep 12. Have them send an ambulance, paramedic crew, light IV, D5 and W, KV. You got it?
Yeah, North Bank General Hospital, 932-1000 set. OR6 contact. Anesthesiologist Isadora Turek, 472-2112, beep 12. Ambulance with paramedics and IV, D5 and WKVL.
That's good.
Sounds like a structural hematoma to me.
Oh, it does it? Well, it's not your job to diagnose.
But I thought...
You thought, just go! 3 years of nursery school, you think you know it all, but you're still wet behind the ears. It's not a subdural hematoma, it's epidural. Ha!
All right, so the little girl gave a great example of a read back. I don't think that Steve Martin did a good job of showing an example of how we create the right kind of culture that invites people to speak up if they have a question. So as I said, the read back needs to be verbatim. We should acknowledge when someone asks us to do something. How many times have you been in the operating room and you've asked the nurses to check something, and if they don't say anything, you don't even know if they heard you? So it'd be so nice to say, can you go ahead and get me the warm saline? I'm about to test my anastomosis. And then if they say, okay, I'm going to go get you the warm saline, I'll be right back, or I'll just get you the warm saline, then I know that they've heard me, and I know that they heard what I said or what I tried to say. Now there are some times when I say something I don't mean, and they'll say, do you really mean that, or do you want something else? And I love it when someone will correct me, because I feel like they've got my back. It's one thing to get people that will work with you and sort of follow along, but you know what? You want to work with people that are going to tell you if you have spinach in your teeth, right? They're going to keep you out of trouble. So we mentioned the shared mental model and the importance of recognizing certain assumptions. And when I'm the associate clerkship director, and when I have a new group of medical students, one of the first things I tell them is the way things have been done on the previous services are likely not the way that it's going to be done on this service. Because every service has their own personality, attendees have their own ways of doing things, the residents have their own ways of doing things, and you have to get clarification. And this takes me to the second skill that I talked about, and that's a check back. Somebody asks you to do something. Mr. Jones spiked a temperature. We're going to get a CT scan. Let's make sure that you call me with the results. And then the resident might say, if the CT scan doesn't get done until 1 in the morning, do you want me to call you no matter what, or do you only want me to call you if it shows a problem? That's a check back. And then if when you finish the CT scan and you call back, the CT scan showed a problem. That's following through. That's having closed loop communication. So this next study that I'm going to show, I thought it was so interesting. This was done by Dr. Fitayakon, who is at Brigham and Women's, and he's a professor at Harvard. But they did this interesting study. They showed these case scenarios, and you could read the case scenario up there. And they gave this case scenario to the residents, and they gave the case scenario to the attendings. And they said, if this situation occurred, would you call the attending? And they asked the attendings, if this situation occurred, would you like to be called? I'm assuming you've all had a chance to look this over. 43% of the residents said they would call. 77% of the attendings said they would want a phone call. Another example, I'll give you a moment to look at that. With this example, 54% of the residents said that they would call the attending. 92% of the attendings said they would want a phone call. So it's important to have this closed loop communication. Check back, get clarification on what the expectations are. Okay, now I'll tell you a little bit about how I got involved with this whole team training thing. When I was an assistant professor, I had just been at Northwestern for a little while, and the chairman of the Department of Surgery said, does anybody here want to get involved with a patient safety project? So, I was new, I didn't have any kids, I was eager to get involved, so wisely or unwisely, I raised my hand. And I had to come up with some sort of patient safety project, so I was looking at the literature and figuring out what can I do that's different at our institution. And at this time, sort of the hot topic was this idea of crew resource management and bringing this approach that they've used in aviation industry to improve the safety to the operating room. Well, in 1999, the Institute of Medicine had made this recommendation that all health organizations need to institute a team training program. And I got involved with this about 2004. So this Institute of Medicine recommendation really hadn't taken off. And I kind of struggled in how do we get started? Well, luckily, the American College of Surgeons at this time had actually partnered with some pilots from United Airlines, and they had a team training program. So I went to this team training program, and it was taught by Don Moorman, who at that time was at Beth Israel Deaconess. So I had Don Moorman come to our institution and give his presentation to me and 2 other nurses to see if I could just get a little bit of buy-in. They thought, yes, this is something that our institution needs. So then he came back, and we gave this 4-hour presentation to the leadership of the hospital, to our CEO, to all the chairs of the departments, and we got the buy-in from the institution to move forward with this team training program. And we had tremendous support. We decided to take an approach where we would train everybody sort of all at once to get a big bolus of this team training. And so they actually closed down some of the ORs for a few days so that people could attend. And we trained 1,100 people in 2 weeks. And we ran several parallel courses. But I will say that the institutional leadership at Northwestern was phenomenal. They really had a vision that this is something that they wanted to do, and they gave us the support that we needed. This is the transition of crew resource management from aviation to medicine. Started a lot at the University of Texas with Brian Sexton and Robert Helmrich. And Helmrich did a lot of the original crew resource management for the aviation industry. And this is a survey that they did to sort of compare the culture of the pilots that have to surgeons. And this is when the crew resource management has been going on for a while in the aviation industry. And this is really just the beginning of introducing it into medicine. And they asked the question, there was a statement, when I'm fatigued, I can perform well in difficult situations. Or I should say, when I'm fatigued, my performance is limited. And 74% of the pilots agreed, and only 30% of the surgeons agreed. And then they made this statement, that junior members of the team should be free to speak up when they have a question or concern. And 97% of the surgeons agreed with that, but only 55% of the surgeons agreed with that. So I think that our culture in the last 10 years or so has really moved forward, and that I think if we gave this survey, even in institutions that haven't done any kind of team training, you wouldn't see that much of a discrepancy. So I've talked about 2 tools already. I talked about the read back, where you read back verbatim when someone asks you to do something. I talked about the check back, the importance of closed loop communication. And this is a 3rd tool. And this is a surgical safety checklist. And you know what? It's just a tool. This is not the beginning and the end of creating the a culture of patient safety, but it's one tool that we have. And the purpose of this checklist is to try and create a shared mental model among the team. So when we implemented the checklist, we called it a briefing. And this is sort of for the World Health Organization came out and called it the checklist. But we wanted to see if this made sense. So we kind of did this pilot project when we first introduced the checklist or the briefing. And we said, as a result of participating in a briefing, did you feel that there was improved communication? Did the briefing help understand the plan of care? Did it improve the familiarity with the team, and did it help with the teamwork? And you can see, similar to that slide that I showed, one of my first slides, the surgeons thought, this isn't so great, this is okay. But the nurses and the anesthesiologists, they loved it. They loved knowing what the plan was. They loved having some expectations and being able to prepare for later on in the case. Then we said, what about those cases when a briefing wasn't performed? Do you think that if a briefing would have been performed, was there a problem that arose that could have been solved if you would have taken that time to run through it, the checklist in the beginning? Was there tension recognized in the operating room that could have been alleviated or at least mitigated with a briefing? And do you think that by not doing a briefing, there was some effect on the team familiarity? And I think if you look at this second column about tension, notice how the nurses and the anesthesiologists really ranked the level of tension much higher than the surgeons did. And I think sometimes we're just not necessarily aware of how as surgeons, how our behavior can affect the rest of the team. So one of the challenges when you introduce these team training programs is, how do we know that it's making a difference? Brian Sexton and Helmrich, they came up with this safety attitudes questionnaire. Instead of just, in the aviation industry, it's hard to see if you're making an improvement by looking at if there's fewer plane crashes, right? That's not a very easy measure because they're few and far between. So they created this cockpit attitudes questionnaire to use that as a surrogate for measuring the safety culture on the airplane, and then they adapted that to the operating room. And so we administered the safety attitudes questionnaire right at the time we started the team training, right at the beginning, and then a 6-month follow-up. And you can see that people commented that they felt more free to speak up. They felt that the leaders kept people informed, and they felt comfortable telling others that they need to take some action. Or in terms of feeling uncomfortable, it was less feeling of uncomfortable telling others that they needed to take some action. So this was some of our original work. And the other thing that we did is we wanted to see, does this really affect communication? So we had 2 observers go into rooms and watch for communication errors. And we had a certain checklist and what counts as a communication error, what doesn't count as a communication error. And we did 150 hours of observation both before and after the team training. And these are examples of some of the types of errors that we looked at. Certainly, it's a communication error if the anesthesiologist asks you after the incision if you want antibiotics. We looked at the subjects of communication errors, and we looked at before team training and after team training. And we saw that there was much less communication in some of these areas. There still seemed to be a lot of opportunity for improvement in communication about equipment. So people sometimes complained at the beginning that the briefing was a little bit of a waste of time. But if you look at the communication failures that we observed, we looked at what are the results or the effect of those communication breakdowns. 23% resulted in a delay. Inefficiency would be like opening an instrument that you ended up not using. And 6% of the time there was a procedural error. So we kind of took this back to, this was useful information to take back to people and say, listen, this seems to be worthwhile. And since that time, there's been a lot of other institutions that have implemented similar types of programs, and every institution has their own culture and their own way to do it. And the way that we did it at Northwestern would not work here. It would not work at another hospital. I think any program that you do to try and improve the culture of an institution, it has to be homegrown, because it has to fit in with your people and your culture. This is a study that they did out of Hopkins, where they looked at different hospitals and they looked at changes in complication rates and changes in their safety attitudes questionnaire, and you can see that there's a linear relationship. This is a study that came out of the VA system, where they implemented a team training program at various hospitals. And 1 year after implementation of this program, there was an 18% reduction in mortality. An 18% reduction in mortality. Now, this is an article that just came out from Canada. They said, we implemented the checklist, we saw no change. And so, you've got Atul Gawande going, oh, I wonder what's going on. And so Lucius Leap, who's one of the leaders of this Institute of Medicine, made some commentaries on this. And one of the things that was noted about this study is that they basically implemented the checklist, and they didn't tie in all those other aspects of the communication and the establishment of a culture. So in the last few minutes, this is a recent data from the Joint Commission showing how leadership and communication is consistently one of the most frequently identified causes of sentinel events. So, in the last couple slides, I want to take a moment and talk about how do we establish that culture? How do we become a leader? Is leadership a position, or is it a behavior? And I think that everybody in this room can walk out of here tonight and be a leader. And so how do we influence people? This is one of my favorite books on leadership. Old school, very simple, but this will give you some nuggets that you can walk away with. Number 1, don't criticize, condemn, or complain. I'm like, really? How do you get somebody to do something if you don't criticize them? How are they ever going to get better? And this book is wonderful. It gives lots of examples, but you have to figure out how to word things in a way that are motivating. You can't criticize, condemn, or complain. Because you know what happens when you criticize somebody? They push back. Their ears turn off. They don't listen. And it's so predictable when we have the NISQIP data and we present it to the surgeons or the teams, and we say we need to improve in this, we're an outlier in the bad end of the caterpillar graph. The first thing they said, that data can't be right. There must be something that, if you criticize someone, the first thing that we all do is we don't believe it. give honest and sincere appreciation. It has to be sincere, or people aren't going to buy in. But you look at the opportunities to give someone a compliment. Even if they've made a mistake, figure out something about what they've done that you can compliment them about. And then arouse in the person an eager want. Think how hard we all work. There's nobody in here that's not passionate, that doesn't love what they do. And it's just helping to support each other as we move along at the different phases of our career. There is no more beautiful sound to an individual than the sound of their own name. So one of the things you can do is learn people's names and call them by name. And two of the most powerful words that you can use is thank you. When you're done with a case, before you walk out of the room, say thank you. It's a very little thing, but it can make a big difference. Finally, I'm going to talk about our hierarchy of needs. So I think about these third-year medical students, maybe a new intern, they're walking into the operating room. You know what? They just don't want to get hurt. They don't want to get cut with the scalpel. They don't want blood splashed on them. Their needs are very basic. The next level is we want to feel a sense of achievement. Those times when you're feeling tired and discouraged, at least for me, when I feel like I've really helped the patient or the patient's very grateful, that's what really buoys my spirits. And we want our residents to come in and feel like they've come in and done a good job. The next level is feeling belonging. Imagine that everybody comes into the operating room, you do a case, it might be a really routine case, it might be a complicated case, but at the end of the day, when everyone feels like they worked as a team and they belong to this team, they're part of it, that makes them feel more motivated to do their best work the next time. And finally, I sit on the admissions committee at Northwestern. And one of the things that we do for our supplemental application is have them write a paragraph about the kind of physician that they want to be. And these applicants are amazing. They've done so much leadership work, they've done all this research, and they write these paragraphs that articulate the vision of what they want to be when they're a doctor. And I feel like all this wonderful energy that they start out with, by the time they get to the third-year surgery clerkship, they're just deflated. You know, they're back at the beginning, just wanting to not get hurt. And so I say to the medical students, and I'll say to everyone in this room, there's going to be times when you're tired, when you're discouraged, and you need to think about when you decided, I want to be a doctor, and the vision that you had for yourself to be a doctor. And that is sort of the thing that we should be aiming for and trying to achieve on a daily basis, is becoming the vision of who we would like to be. I'm going to end there. Thank you.
Very inspiring and exciting. I think I also appreciate all the insights that you gave us about operating in the operating room. It's all about people, after all, right? We have time for questions. Any questions or comments for Dr. Halverson? Matt.
So in your work to roll out not just the checklist, but sort of the entire emotional and mental components going around the checklist and why it was so important, how long did it take to really get that buy-in and really start to see it become a solidified part of what everyone does every day?
That takes 3 to 5 years. But there's 2 important things that we did. One is bargaining. We bargained with the neurosurgeons and orthopedic surgeons. We had to throw them a bone. They were not enthusiastic about this. So we said, if you get in there and you have assigned to you a scrub nurse or a circulator that you think can't keep up with you, and you know who I'm talking about, Dr. Rosen, says, I can't work with this nurse, they're too slow. They have the ability to call in the nurse manager and say, I need backup for this. And we also give them the opportunity to designate a critical part of the case where there's no handoffs. Have you ever been operating and like you're operating and like there's this little, I have Nietzsche, this little Korean nurse, and then suddenly I look up and there's Hervé, this huge tall guy, and I'm like startled because they have this stealth handoff. So we've eliminated the stealth handoff. But given those neurosurgeons that bone where they can say there's not going to be a handoff, I don't care if it's lunchtime. When I'm clipping this aneurysm, there is no handoff. So we did that for them. And then what we had to do is we were kind of like, who's the leader in the OR? Who's going to lead the briefing? And this is how the briefing went in our operating room. Like I would say, hi, I'm Amy Halverson, and we go by the first name. And today we're going to do a sigmoid colon resection, and I want to make sure I have this EEA stapler. And then the scrub person would like say their name and turn around and start unwrapping this stuff. And that stuff is really loud, that autoclave paper. And then the resident would like go answer a page. And then the anesthesia person like says one thing and they turn around. And no matter what, the anesthesia attending comes in and interrupts. And so I do this nice briefing. At the end of the briefing, it's just me and the medical student. And I'm like, please feel free to speak up if you have any questions during the case. And so what we did is we put the briefing in the hands of the anesthesiologist. Because at the very beginning when you roll in the room, that's when they're sort of driving the tempo. And there was no like good time where we could have control of that. So we had them do the briefing, and they totally own it now, and they do a great job with it. But that's what made it work at our institution. And it took a while for it to become routine, and we had to give it to the anesthesiologist so that they would respect it. Because they would just walk, you know how the attending just walks in and out of the room. And no matter where you are in the briefing, they just walk in and out and pay no attention until you make them be in charge of it. So that's what we had to do. Yes?
First of all, it seems like you were scarred last time you were 1 month on neurosurgery. So you can imagine what happened to me at 7. The question I always have with these things, as you said, the purpose of the checklist is not the checklist per se, but all the surrounding environment that occurs as a result. And one of the things I've noticed, in particular with the EMR and stuff, is that anything that gets assigned, in essence, becomes the task of itself, and it becomes very shallow. How do you keep the focus from checking the checklist to actually being the depth and thought processes around it that you really want?
So we don't really have an actual checklist that people have to check. We kind of did that in the beginning, and that's kind of faded. And I think that you need to do that in the beginning as an exercise to get people comfortable with it. But now it's sort of the culture that people don't, well, people don't really move forward, but we did make a rule that the patient does not get intubated until there's been some briefing. And it can be, there has to be one attending. It can be the anesthesia attending, or it can be the surgery attending. So it doesn't really slow things down. But we've tried to make it the spirit of the checklist and just say, you gotta do something. I think one thing that's really valuable about doing a checklist is having everybody in the room say their name, because it gives them the opportunity to have their voice heard. Someone who's quiet and shy and isn't comfortable speaking up, at least there's now a ritual where it's important for them to speak up. And that, I think, is maybe the most important thing about it. I mean, part of it is the nuts and bolts, and I still get anesthesia residents who are like, do you want antibiotics for this colon resection? Yes. But giving the people who don't necessarily feel comfortable to speak up the opportunity to have their voice be heard, I think that's important.
Amy, can you comment about the 2-question rule? Do you have that in your
Yes.
institution?
Yes. So there's the idea of the 2-question rule, and I kind of touched on it with the idea of I want to clarify and confirm. And the idea with the 2-question rule is if somebody asks you a question, or you kind of say something, someone questions you. If they question you once, you kind of go on. But if someone questions you twice, you need to really stop. And that's kind of where that clarify and confirm come in. And I didn't go into this, but one of the things that we do teach, and it hasn't caught on at our institution, but a way to escalate a situation without escalating the emotion of it, that is taught like with the National Teen STEPS program, is to have these trigger words, and they call them cuss words. I'm concerned, I'm uncomfortable, this is a safety issue. And if you're at an institution where you implement that and everybody knows what those words mean, that can be useful. But I feel like in the absence of sort of the whole institution adopting those words, being able to just say, I want to clarify, I want to confirm. And those are not offensive. Those are not threatening. But that is a challenge.
I think doing the checklist and briefing as soon as the patient comes to the room makes complete sense, because if there's a problem, it can be identified and rectified at that point. How are you adjudicating the recent guidelines by the Association of Operating Room Nurses, where they want to do it only right before you pass the night, which seems quite late? How have you
Yeah, so
those two cultures?
I totally get that you don't want to repeat the whole thing. So we do have this sort of moment of pause, and it can just be like a very short pause right before the knife is passed. And that's when we just clarify the site, the procedure, and the patient. And so it's really quick. It takes like less than 3 seconds, but it's still a pause. And what can happen is, like, when from the time you go into the room and do the briefing to the time you actually make the incision, it's 30 minutes, an hour, can be longer. And so that's when the things that were brought up at the briefing are now clarified. Okay, when I did the briefing, we only had one antibiotic. We didn't have both of the antibiotics. And I always have to say, are the antibiotics in? Because at the briefing, you've got the anesthesia resident that's kind of there, oh, I've got these antibiotics, and they're sitting on the table. And I'm like, can you please start infusing them? But when I do the timeout, if I know that they weren't hanging when I did the briefing, I'll look up and I'll say, are they actually in? And so, but that's how we streamline it down to what we think are the essential things. Right patient, the right procedure, we just kind of clarify that, and then are we at the right site? So it's really fast, but it still gives you that moment, that pause.
Can you comment about the debriefing, before the patient exits the wound, exits the room? How effective is your debriefing for the case?
My debriefing is terrible. I tried to do a debriefing and I failed miserably, but I'm going to try something new. So I can tell you, I have this thought, I want to talk to the patients, what did we do well, what did we not do well, and I was like, you guys did A, B, and C well, and you had all the equipment I needed, but it was on the table and it wasn't open, and so next time can we open the equipment in advance? I'm giving you an example, and I thought that was a really good debriefing. And I walked out of the room, and the resident comes up to me later, boy, those nurses were so mad at you. They worked hard, they had everything ready, and you still had something to be negative about. So number one, if you're the surgeon, you don't necessarily lead the briefing. And I just came back from a master training team steps, and this is my new answer, okay? And I have to put it into practice. But you open it up to the group, and you say, what did we do well today? What can we improve on? And you don't say it, you let the group come up with it. And if you do that after every case, when it's routine, people are in the habit of doing that. And maybe you're not going to do it after every case. Maybe it's going to be at the end of the day. And I know there's the issue where the people that started out in this case are not the people that finished the case. But that's what I think would make more sense, because I think the debriefing is hard. But I think you have to figure out something that works for your institution. It needs to be routine so that people don't get stressed out when there's a problem and you're now calling a debrief. So what do we do at our institution? Our debrief is this. I go with the circulator nurse and I clarify, this is the procedure, this is the specimen, to make sure we're clear on the specimen, because at our institution we had some specimen mishaps, and the wound classification. And now you're going to see this article coming out that the wound classification means nothing to surgical site infection. But that's what we do, because we felt like it was important to verify the wound. So that's our debriefing, and it's nothing about the performance, but it's what we do. So we certainly have room for improvement.
I think this is a great discussion of something that we live every day as surgeons, the operating room conduct. Before we give you a couple of gifts to show you our appreciation, I just want to make two observations. One, it's nice to see that a place like Northwestern doesn't have that much over West Virginia University hospitals in the operating room. that you have the same sorts of problems that we do. And I think, secondly, that Dale Carnegie would be proud. I think that you've been a great lecturer. We're looking forward to your lecture tomorrow on rural surgery. We have a couple of gifts I'd like to present to you, and then we'll adjourn. Amy, thank you very much.
Thank you.
There's a check in this one.
Oh, no. Oh, wonderful. Oh, great. Thank you so much.
Gus and Rick, I did that picture of you and Easy. Thank you very much.
My pleasure.
Get that short conversation. Still do war management stuff.
Do I? To some extent, I do it. We do orientation to all the new people, and we had been doing it every quarter, but there's been a lot of transition in leadership, so it's kind of died down a little bit, but certainly all the new interns that come in, and I do it with all the medical students. Okay. Oh, do I? Oh, no, I'm good. I'm good. Let me just get my Bob. I didn't mean to pick on the neurosurgeons too much.
I gotta go with the family and stuff, but it's so good to see you. So pleased to see you doing so well. You do well.
Okay.
I won't be tomorrow. I've got my own department.
Oh, yeah.
So I won't be able to attend.
Oh, okay. Oh, that'll be good.
Great.
Oh, yeah.
Yeah, I'd love to get a copy.
Thank you.